A 67-year-old man with a known history of Crohn's disease presents with acute abdominal pain and severe bloating. I am showing you an initial CT and an MR enterography performed 2 years later. Describe the findings.
Right, so the initial CT demonstrates focal asymmetric wall thickening and hyperenhancement of the distal ileum with surrounding fibrofatty proliferation and significant luminal narrowing. The follow-up MR enterography 2 years later shows persistent, severe mural thickening and fixed luminal stricturing at the exact same ileal segment, with pre-stenotic bowel dilatation.
What complication of Crohn's disease has this patient developed over the 2-year interval?
The patient has developed a chronic fibrotic stricture, leading to a mechanical small bowel obstruction.
How do the underlying pathophysiology and radiological features of an acute inflammatory stricture differ from a chronic fibrotic stricture in Crohn's disease?
An acute inflammatory stricture is caused by severe mural edema and spasm. It shows marked hyperenhancement, restricted diffusion, and the comb sign, and it is reversible with medical therapy. A chronic fibrotic stricture is caused by irreversible scar tissue. It shows fixed narrowing, minimal active inflammation, and requires surgical or endoscopic intervention.
What other specific chronic complications of Crohn's disease must a radiologist actively search for when evaluating a stricture?
The radiologist must carefully search for penetrating complications proximal to the stricture, specifically enteroenteric fistulas, enterovesical fistulas, and localized mesenteric abscesses.
If this stricture were found in the duodenum or jejunum and had a rigid apple core appearance, what alternative diagnosis must be excluded?
In that case, a rigid apple core stricture in the proximal small bowel would be highly suspicious for a primary small bowel adenocarcinoma, which patients with long-standing Crohn's disease have an increased risk of developing.
How would you manage this patient as a radiologist?
Okay, I would immediately contact the surgical team and gastroenterology to report the high-grade mechanical bowel obstruction secondary to a fibrotic stricture. I would present the case at the Inflammatory Bowel Disease MDT to plan for a definitive surgical bowel resection or stricturoplasty.